So good morning, everyone.
How are you?
We'll go ahead and move right into our panel about converging pathways, training pathways, really, reconciling training gaps and practice realities in otologic and neurologic care. I'd like to spend a moment to introduce our panelists. Samantha Anne from the Cleveland Clinic, here all the way to the left of me, the right of you. Dr. Doug Backous from Seattle. Jacques Herzog from WashU, Rick Nelson from IU, Jacqueline Weinstein from the University of Cincinnati, and myself from Ohio State. Here are disclosures. None of those are really, relevant for the current panel. So really, what this is a panel, and I think Colin mentioned it early in the business meeting, or Rick mentioned it, that was basically a merger of two panels where we try to examine how the different training pathways that get you to become an otologic surgeon or neurotologic surgeons, really, if those different pathways do meet the current demand. So the sense of the group was that there's a real need in the population for otologic surgeons, but maybe we are training too many neurotologic surgeons, right? So we really, do the current training options really meet the population demand? And we really are, I mean, at least the ones of us who are in academic medicine responsible for preparing surgeons for the patients we serve across these different training pathways. And should the field consider clear expectations regarding competency, case volume, and training structures? And again, competency for our trainees is really an outcome, and we're partly responsible for this. So we're not here to decide who should or should not do surgery. We're here to explore, again, how the field should think about preparation, competency, and responsibility. Training variability, so what are the different pathways? We all are aware of these. Just to recap, right, we can do the ACGME Neurotology Fellowship. I assume the vast majority in this room is currently either in training or has completed that. An ACGME Pediatric Otology Fellowship, and we have Dr. Anne here, and again, Dr. Weinstein is currently, was a pediatric otologist who's currently a neurotology fellowship in Cincinnati. Right, so we'd love to hear her perspective on a lot of these things. Advanced Otology Fellowships with Dr. Backous here, who's a fellowship director of one of those. So we'd love to hear your perspectives, Doug. And then again, residency-only otologic surgeons, which seems to diminish as we over time, at least during my career. And again, these pathways do increasingly converge in practice. So who does otologic surgery can come really from any of these different pathways. Christine then helped us to put a little audience poll together. So if you can basically scan this QR code. Unfortunately, we don't have a way to display the results live because of internet connectivity here. And you didn't get that one? Okay. Well, we'll skip that. There are two more. There are two more. So we were not sure because we don't have, again, internet connectivity of the presenter computer. So really, to recap some of the case numbers, ACGME training in otolaryngology, right, has a requirement. I highlighted it here in yellow. As you can see, our trainees, again, resident trainees, need to complete 17 tympanoplasties, 15 mastoidectomies, and 10 stapedectomies / ossiculoplasty cases, total of 42 cases. So very limited case number, we would all probably argue. Pediatric otolaryngology, again, 1 year ACGME approved pediatric otolaryngology fellowships have a requirement of 30 otologic cases, right? And advanced otology fellowships, they have a different application mechanism, usually advertised to the otologyfellowship.com website, and I just copied and pasted into this slide here what's part of the website, and these are some of the programs that are offered here across both the United States and Canada. And lastly, we have ACGME neurotology case numbers with 25 skull-base approaches, really not specifying the specific approach. We have 20 tumor resections, and the other categories listed here. Most of us are intimately familiar with these case numbers. We put together a quick slide. It's pretty intuitive to everyone, I think, here, what the different exposure levels are for both adult and pediatric cases with the different training pathways. I think we'll all discuss this during the panel, so I don't want to belabor this here. I think Rick wanted to briefly talk about the recent ANS survey that was published recently, so take it away.
Thanks, Oliver. So in 2024, the ANS Fellowship Committee designed a survey that many of you took, and so we thank you for your response. We had actually a pretty good response of 24 members. 24% of the members responded. And interestingly, when you look across the spectrum of experience from 1 year out from fellowship to 30 years in practice, it was pretty equally distributed. And as you can see, 91% of them completed the ACGME fellowship, or they had completed a fellowship prior to when it became ACGME accredited. And many of them were in academic practice. This is the publication that was in 2025, and I really want to thank Mike Harris and Edward Hardrex and the rest of the team for publishing this work. So from this work, we asked the respondents to tell us what number of cases for a specific approach they thought were required to achieve competency. And so we asked them individually, translab, retrosig, middle fossa for a tumor, or middle fossa for a non-neoplastic condition such as superior canal dehiscence or CSF leak. And as you can see, it's a pretty Gaussian distribution, and most of them fall in that range of 11 to 20 cases. Some are 21 to 30 cases. And as you can see, we took the minimum, we calculated a minimum number required in each of those categories, and that's listed on the right. So for translab, it's 20 cases, and the significantly lower was a middle fossa for non-tumor, which maybe we all think is kind of intuitive. But total, if you add all of those up, we had 66 cases to achieve competency. If you remember, all approaches for skull-based tumors for our current ACGME requirements is 25 cases. Now we can argue, do you need to have all these approaches to be competent in all of them, or can you become competent in a retrosigmoid, for example, if you do enough translab cases? So we did not ask that specific question in general of total cases. Also interestingly, as you can see, middle fossa for tumor, some respondents do not use this approach. And then we asked the participants, once they're out in practice, how soon after practice, the number of cases would they need to do before they achieved comparative outcomes to the literature? And most of those fall towards the left, within maybe 10, 20 cases. Again, interestingly, that the middle fossa approach for tumor, many of the participants don't use that approach in their practice. Then we went on to ask the participants, do you think a translab approach, since it's what we think is a hallmark neurotologic procedure of our specialty, allows us a distinct approach to the skull base that's specific for neurotology, do you think that that should be a requirement for fellowships? And 85% of the ANS members said yes, that should be a requirement. And if you did say it was a requirement, how many minimum cases do you think would be required? And again, the average was around 20 cases. So to summarize that, I think we'll have a discussion, but I think in relation to our current numbers, it seems that our numbers may be too low for fellowship requirements, and that translabyrinthine should potentially be a requirement for each fellowship. So we'll go on to the audience polling.
Yeah, since the audience poll is kind of not really working right now, or This question is working. So we need to go back to the previous QR code. I put it up again. Sorry. Okay, sorry, almost there. So here we are. If you scan this code here, I'll do the same. Okay, and people are still voting here. So what I have here on my screen is about half of you feel this question would be answered as essential, another 30% as helpful but not required, and then another 23% as procedure dependent, and a minority as not important. I don't know, Jacques, any thoughts?
So I came at a different era of training when fellowships were not certified with ACGME, and there were a variety of different places people would go to gain the expertise. And I was fortunate to train with Ugo Fish, who had a comment about expertise, and it was you need to deal with the temporal bone from every direction. You know how to operate on the temporal bone from above, below, anterior, posterior, and that lays the groundwork for being a competent, and I like to use the word excellence, surgeon when it comes to dealing with complex otologic surgery, complex chronic care. And I like to tell the people when they apply for our fellowships that the day they finish there, while we emphasize neurotology as our core in the training in the fellowship program, the day they finish and start their practice wherever, they will be considered the otologic expert when it comes to referrals from our otolaryngology colleagues. So it really does set the groundwork for being able to handle these complex otologic procedures, whether it be fissures of the lateral canal, extension intracranially, sigmoid sinus, what have you.
Doug, any thoughts?
Yeah, so we with our Otology Fellowship, if you even look on our website, it says you will not sit for the ACGME board. But I have a very significant lateral skull-based practice, and the other side of the fence is what we call it. And it's not just the surgical approaches. We focus on this a lot. It's how do you care for a patient that may have an intracranial complication from a sigmoid sinus occlusion or a mastoidectomy. So our fellows work extensively with the neurosurgeons around perioperative care. And the ear is, in residency, it was pretty cool. When the fellows get into it, they realize it's pretty complicated. And if you don't know what's on the other side, my contention would be you're probably not completely trained.
Okay. Rick, any additional thoughts?
Yeah, I think clearly the volume, I think we'll discuss that, but volume of cases, I think we can all agree, tends to correlate with competency. And so I think if you're doing skull-based cases, then clearly it makes you a better otologic surgeon. I would say that talent comes in many ways, and they come in many patterns of training. So I chose helpful but not required. I definitely think as skull-based surgeons, we're excellent complex otologic surgeons, but I think you can also be that way through other mechanisms.
Jacqueline, since you have different training path background with first a pediatric otolaryngology fellowship and now neurotology, any particular thoughts on your end?
I think we'll get to some of the other questions this verges on sort of later in the panel as we pose questions about additional training. But I think I probably, filling out the survey, would put in the helpful but not required. Obviously, I've very, very greatly value the addition that skull-based surgery has added to sort of my clinical life. But actually, when I was discussing with Dr. Pensack sort of what my practice might look like after, I remember him saying, you know, your skull-based training is like a pair of Manolo Blahniks where you're going to take it out under certain circumstances. You may not use it every day in your complex otologic care, but it's something that you will lean on, you know, for complications, sort of the other side of the fence. I came up in a milieu where I saw many, many pediatric otolaryngologists practicing complex otologic surgery without complication and able to sort of, handle any eventuality that they encountered with cholesteatoma. So I think in my mind, it's been an amazing adjunct for me, something I greatly value, but nothing that I felt is essential to doing. I think there's many ways to come to this, sort of like what Dr. Nelson said.
Yeah, Sam, as a pediatric otolaryngologist, what would you tell pediatric ENT trainees that really have an interest for the ear? How do they can hone in their skill? How can they become competent ear surgeons?
So, Oliver, real quickly, I was going to say those ACGME numbers are like bare minimums,
Yeah.
and I talked to a lot of the pediatric fellowship directors, and the PEDS fellows far exceed those numbers. Sick children's, and with Sharon Cushing, they would do over 200 pediatric cases, complex ears.
Those are just minimum numbers, right?
Yeah,
It's
exactly.
just ACGME.
Like David
Absolutely,
Shee, Pittsburgh, like over 100. Daniela Carvalho, Stanford, like over 100.
Absolutely. Yeah.
So, in my eyes, if it involves a skull base, I'm not messing with that, and I will know that on the CT, right? And I'm going to recruit you guys to help me. So to me, I did a pediatric fellowship, and I know I can list off a ton of pediatric otologists that did PEDS fellowships, and they're fully competent, and they're doing ear surgeries, and they're fine. I think the key is having insight and knowing what the limit is. And I do all complex ears, all cholesteatomas, and we all can probably agree that pediatric cholesteatoma is probably the toughest decision-making and anatomy and skill set that we probably do in complex ear. So in my eyes, I agree with you. Like if it's skull base, that's neurotology. I'm not going to encroach that, but I'll know that on the CT. And in the small chance where I think there might be a need for, then I enlist, Mark Bassi, my partner, and have him jump in if needed. But there's a pre-warning to Mark, it looks like it potentially might be involving skull base. So I think you don't need it as long as you have awareness of, and experience to know what you're dealing with.
Yeah, thank you for your thoughts. Yeah, since we all work with pediatric ENTs, I think the training numbers, Sam, to go back to that, right? I mean, some fellowships in pediatric otolaryngology seem to be really focusing on otology, right? But it seems like there's some variability at least.
Oh, 100%. And I think it's the same for neurotology, right?
Yeah,
Some
absolutely.
programs get 0 peds, and then some get a lot of peds with you, for example. It's the same with, I knew I wanted to do ears, so I picked the Pittsburgh Fellowship because I knew I was going to do ears. So there's some self-selection amongst people. We all gravitate to what we like. So there are definitely peds programs that are very ear-heavy, and I think a lot of fellows select to that. In terms of what you said, what do you tell trainees if they're trying to decide from doing a PEDS fellowship or a neurotology fellowship if they want to do kids' ears? Dana is one of our residents, actually, is interested in both. What I tell her is, what's your passion? Do you like kids? If you like kids, do a PEDS fellowship. But to get really good at kids' ears, you got to be a Dan Shu, you got to be a Nancy Young, you got to do a bunch of kids. So that's one thing I would do differently is I did everything in the beginning and just honed on ears. I would say from the beginning, if you know your passion is kids' ears, do kids' ears all the time. Focus your practice early on, and the faster you get your experience and, develop the skill sets and, the decision-making, and a lot of the PEDS, cholesteatoma, and chronic ears is decision-making. So that's how I look at that.
That's great insight. Yeah, Jacqueline, any thoughts?
I just want to say, I think that we focus a lot, of course, and I think in particular here on the sort of technical differences between the fellowship, but there's also a just massive philosophical difference in sort of what a pediatric otolaryngology fellowship is versus what is neurotology fellowship. In PEDS, you're sort of the medical home for this complex child. You're doing their, airway considerations, you're working with a pulmonologist, you have a texting relationship with the cardiac anesthesiologist, and you really are sort of doing this wraparound, pediatric care. This came very much up for me when I was at a branch point in my decision making about what is the next career move? And I had to ask myself that question that probably your trainees are asking. Do I want to be primarily in a peds, quaternary, tertiary environment, or do I want to be a neurotologist who also does, a large amount of pediatrics? It is indisputable that my neurotology training has made me a better ear surgeon, expanded the boundaries of what I was able to doing, and it was a personal decision for me that, of course, I could talk more about, but that I really never wanted I never wanted to be in question sort of what I was capable of doing surgically, but I think it's also it's not just what are your numbers difference, it's also just what does the practice environment look like? Because I do think, and you'll see this across the landscape nationally, that there are many, many pediatric otolaryngologists who are providing complex otologic care, and that this distinction is one that's sort of historic and convention-based. Now, when I was a pediatric otolaryngologist, did I call upon my neurotology colleagues for help in certain? Absolutely, 100%. But I think it's not just a question of the case numbers are different and technical aspects. There's also just a sort of multidisciplinary bend and medical home to the pediatric otolaryngology fellowship that I think is different.
Thank you. Do you guys think there's a need in well-trained pediatric otologic surgeons, both on either training pathway? Do you think there's a population need there? Something I said earlier, but is that really based in fact? Yes, Doug.
I kind of like to take a step back. There's plenty of neurotologists that have great relationships, in particular in academic medical centers with the pediatric groups, and they share cases. And I think that's a great comprehensive care, but we don't really take care of cholesteatomas and stapes. We take care of people. And I think the pediatric groups take such a better care of caring for the kid, and you can't care for the kid without caring for the family. And caring for the family sometimes drives me bananas. And you have the assets to do that in a very comprehensive way. So in that regard, I think there's a lot of value, and there's just some things that are done better at the pediatric hospital.
Yeah, there's things beyond the case number, I guess, that shines through. Yeah, Jacques, any thoughts on this?
I mean, I agree with a lot of what you're saying, and I think you hit the nail on the head, Jacqueline, and that's that the more you do around the base of the skull, the more comfortable you are in a complex chronic ear. And yes, CAT scans help a lot. There's a lot of false negatives and false positives. My fellow will attest to in the OR. And so the ability to handle those situations, your expertise definitely improved having had experience working around the base of the skull, intra or extradurally. And so, I mean, I take my hat off at you doing all of this. Nancy Young did a neurotology fellowship, and that kind of honed her expertise in the same way.
Rick, I know you do some pediatric. You're good.
I mean, I think they covered all the main topics on that.
Okay. Well, let's move to the next audience poll here, I think. Going back to skull-based approaches, what should the minimum number of skull-based approaches be? If you can take a try here, I think. Okay. Results are still coming in.
I don't want to have to log these additional cases if we change the requirements. Do I have to do that? Can I just log them in?
So as the results are still tickling in, right? So the 25 to 40 case bracket currently sits around 19%. 41 to 50 is at 27% now. 50 to 60 at 37%, so that's the highest. All right, and 60 to 70 is at 11%, and more than 80 at 6%. So the trend is certainly quite a bit higher than what the ACGME mandates for our field. Correct?
So I went on the CAST fellowship for neurosurgery and their fellowships, and ours is obviously currently at 25, but a one-year skull-based neurosurgery CAST fellowship, the institution has to have 200 available cases and the fellow has to do 70. And neurosurgical spine CAST fellowships, they need to do 150 for their accreditation. So those are just one-year fellowships, and we're talking about a two-year fellowship. So I think keeping that in mind is also how other specialties are adjudicating their cases.
Yeah, so you think based on this poll, right, you think a higher number, it would really mean increasing the minimum case requirements. Would that be feasible?
I think personally, I think with the 51 to 60 kind of falls within the survey range of where the cases might be, what the survey was reporting. So seems logical to me that that might be sort of a starting point.
Yeah, Jacques, any thoughts from your fellowship?
So we had the comment when we were preparing that this is sort of stuff you talk about on your cocktail at the bar at the end of the afternoon at the meetings, and so we were talking a little about this over the last couple of days, and what do you really think is a viable amount of cases? And it gets back personally, I have my own personal feelings, I'm sure others may dispute, and that is the core of our neurotology experience. What defines us, what defines the ANS is the translabyrinthine approach. That's what got us all into this. And so the question is, how many translab procedures do we have to do to feel competent? And the other thing that we take into account is we are operating on fewer acoustic neuroma patients than we have operated on in the past. In other words, if I see 10 acoustic neuromas, I'm not operating on 10 of them. 25 years ago, we did. And so we have to recognize that those numbers are evolving and changing, and that we're tending to operate on larger and larger tumors. I do think if you take a fellowship, it's 24 months, right? And so how many acoustic neuromas are you going to do over those 24 months? On average, how many a month? And I think that without a doubt, I think doing 1 to 2 per month translab procedures is what's going to get you that competency, I think. And so, but then you get into the other issues of retrosig, neurosurgery. We all work on neurosurgery colleagues, what their preferences are for dealing with smaller and larger tumors. And the middle fossa approach is variable from institution to institution, particularly with philosophies of how you handle a 4-millimeter tumor. And that's a whole nother conversation that maybe another panel someday. But I think that when we talk about developing our core competency in neurotology, it does again center around the translabyrinthine approach.
Any thoughts, Doug?
So I think this is interesting. So we're all faking it if we think that's going to make a competent surgeon. What we're building is a toolkit that people are going to build on through, as Mike Link so elegantly said it yesterday, the shallow learning curve. And are we equipping people with a toolkit to become a better surgeon over time? Part of that is judgment, part of that is experience. And if you're going to be a good skull-based surgeon, you're going to be calling your mentor or calling other people to mentor you around the country for the first 10 or 15 years of your career with difficult challenges. So I think these, and the other question that's real, and this is in my experience as Academy President, when I finished my residency and my fellowship, I paid for my college, my residency, got through my residency, I paid for my own medical school. Thank God I married my wife because she had a job. But my debt was $42,000. And people are coming out of medical school now with $400,000 in debt as an average in our country. And in our fellowship, it's not a neurotology fellowship, but my fellows all do between 41 and 60 skull-based procedures easily in that 1 year. So can you perhaps concentrate the neurotology fellowship? And by the way, how many people at the panel did a 2-year neurotology fellowship? Yeah, and so, not many of us old guys and old women did 2-year fellowships. So there is a financial reality, and if you take 1 year of lost income and actualize it over 25 years career, you're asking people to pay over $1 million for an extra year of training. So can we concentrate the neurotology fellowships, concentrate some numbers, and get it done in less time, and actually provide more of a service to the people that are candidates? And I think the reality is we've got to get people prepared to be continual learners throughout their career. And to this day, I've been doing this for 27 years. I call people all the time.
I think this is really interesting. I remember, finishing my pediatric fellowship and being like, oh my God, I really want to, be faster at this. And I remember, now as I do neurotology fellowship, I'm like, oh, I really want to get my translab time down. And I think it is really important to remember that you're developing a sort of a foundation and I hope, continue to improve throughout your practice and be informed by some of the clinical decision-making you do also during your practice. But I do want to say that, obviously doing a second fellowship, it was like, it is financial hardship. And I do think these considerations around serving the population, what is the correct balance of otology? And I think we're going to get to this. Is there a role for a one-year otology? Would I have done that if there was an ACGME accreditation? I personally wanted the skull-based experience, but I think it's a really good question, and I think it's important to mention that I know there is hardship involved in taking, a 75% pay cut and, doing the various indignities of training.
Yeah, sir.
I agree 100% with, that is a complicated topic to handle. Our current fellow is in his 8th year of training. He's going to have 9 years of training out of, after medical school, kind of, what about gap years and this and that, that everybody's going through. It is very complex, but let's go back to how we got to this in the first place. And prior to, and I'm going to get the dates wrong, 2002, when we initiated the formal ACGME fellowship process, around that time. Prior to that, there were a lot of it was very random. It was preceptorships. You came for a year, you might come for 2 years, you might do this, you might do that. And the whole point was to create some sort of guidelines and guardrails of how we train people. And I have to tell you, to train today is much better than it was 25 years ago. We have didactics, we have core curriculum, we have research commitments, we have tie-ins with academic medical centers, we have volume, regulated volume, and I think that the training today is much, much better than it was a generation ago, and you hate to take a step back. And I think, Doug, I've known you forever. We trained at the same institute, our residency, the same place. I've known you forever. You come from a different lens than a lot of other otologists do in private practice, having been there myself. And I think, like Jacqueline said, it's going to get to another question. Yes, there is definitely a role for an otology fellowship relative to a neurotology fellowship, but shouldn't we all agree there be some sort of guardrails, some sort of generalized accreditation or something, whether it's driven by us, by the Academy of Otolaryngology, or the ACGME, something so that there is some uniformity in training, so that we are able to train our people in a much better way than we did a generation ago, and it'll be better than the coming generation.
Doug?
I would 100% agree. And I think the premise when I sat down with Moy Arriaga and Doug Chen and Todd Hillman about 15 years ago and talked about this was people were coming out of their residency programs not feeling confident in ear surgery. And I will tell you that since COVID, my fellowship has changed. I've had 13 years of fellows. And since COVID, it's been tough. I mean, I've been taking people back to how to make sure you tie a square knot in a wound. And I don't say that to be critical. It's a reality. And so the goal in our fellowship, and I would say that 90+% of my fellows practice general otolaryngology, but are the otologist in their group. And so we're training people to be really good otologists as part of their general otolaryngology practice. That's the focus. They get a lot of skull base because they sit next to me, and my fellow next year actually is somebody who did a pediatric fellowship and is coming back, and he strictly said, I'll do the skull-based stuff to learn it, but I have no interest in doing it. So people are kind of all over the spectrum in that. So I think we're training something different, and our goal is that people can go out and expand their practice. We have an otology conference that's community-based that the fellow runs. We have an annual ear course that the fellowship is part of, and it's exposed to 7 or 8 leading otologists and neurotologists from around the country. So there's a real academic piece to it. We pay for our fellow. My partners, we just write the check, and what the partners get back is the fellows on the call schedule. That fellow on the call schedule, when I do the end of the year reviews, say, being on call alone with you guys behind me was a maturation year for me, and I felt much better starting my practice. So it's really a maturation year, but it is a year that is expensive for them financially. So I think we're targeting something entirely different with these fellowships, and some of them see a lot of skull base, just because the people they do them with do a lot of skull base, but that's not the emphasis necessarily in the majority of the programs. I don't know if that helps.
It does. Well, but let's ask the audience, right? Is there a role for formalizing basically advanced otology fellowships? We have several options here. Yes, yes, but not through a kind of formal ACGME approach. No, or if you're not sure, just click that. Looks like from a preliminary perspective here, 60, 57, some percent of folks present think that we should formalize this. Doug, yeah, so since you have one of these, how would you formalize it?
What's that?
How would you formalize it?
You know, it's very interesting, man. That's a great question, because you don't have to do any of this to do a trans-lab acoustic approach or do a mid-fossa acoustic approach, because most hospital requirements just say you have to be board certified in otolaryngology. So I would say, you know, it would be good to get people together and decide what is a basic competency, and not so much, I mean, numbers are important, but what components of the programs are important. These are educational fellowship years. They're not hiring somebody because you have residency limitations that you can use for hours, and you need someone else to fill in that time. This is an educational experience, and that's how we treat it in our practice. So, and I've moved mine from a hospital-based practice into a private practice. So I would say yes, and I would say you get the fellowships directors and you get some people from the neurotology fellowships, and I would say you get some of the pediatric people in and just have a conversation about it.
Yeah, Rick, any thoughts here? Would you go with the ACGME route?
I think that's probably the most reputable route. I think the point I want to make is we're sort of here to decide how best to treat our patients, because patients come to the surgeon and expect us to be minimally competent, hopefully excellent, but we're trying to decide minimal competency here. And so they go to a neurotologist or an otologist. What does that sort of fellowship certification say about their skill level? And so it's obviously somewhat variable, but I think once they graduate, they should be meeting these competencies. And so if you make it ACGME, at least you have some formalized statement about the competency, minimal competency of otology fellows.
Yeah, one issue may be that, you know, neurotology fellowships require at least 2 faculty, right?
And a university affiliation.
Correct.
And the other is, and I don't recall back when, I don't think there's anybody in this audience that was part of the original 8 people that formed the fellowship committee back then, but I think the 2 years came because the ACGME wanted people to have 2 years. That was also the other part of it. So I don't know if we can go back to ACGME and talk to them, but it might be something to consider. I think the advantage of the ACGME is you actually have, as you mentioned, it's the most reputable way that we can document things.
Yeah. Yeah, Doug?
Just a secondary comment. So even the American Academy now has really increased drastically the education on the business of medicine. So our fellowship, they sit with our office manager every month. They go through financials. They understand billing. They understand collecting. They understand running a surgery center. That's all very important. The problem with ACGME is the academic medical centers all have offices that handle that. That is a hindrance to people having fellowships. So to move to ACGME is going to exclude really good private practice fellowships. And I don't think that's what we're trying to do. And what you would end up with is ACGME approved otology fellowships and non-ACGME approved fellowships. And people just want to operate better. So I think, you know, as an academician in my past, I'd say, well, certainly ACGME. We will shut down the majority of the fellowships or just create yet one more layer of people outside of that fellowship realm if you do that.
Yeah, let's maybe open the microphones for the audience as well. I know there were some questions, so we have, I think, 10 minutes left. Hey, Bill?
Yeah, so let's just do a little history. So ACGME started in 1997. the board started approving fellowships or board certification in 2004. Prior to that time, Jacques, as you mentioned, most fellowships were 1 year. There was no accreditation. Most of them were private practice, and it was kind of a free-for-all. But it was also, you went to the fellowship where you thought you were going to get what you needed, and it was all about training. Most fellowships, requirements for the fellowships also, there was a lot of politics that went in when we became ACGME approved for neurotology. And that was the neurosurgeons were fighting the concept of anything inside the dura. And so therefore it was very clear that we had to do some politics. I was not involved, I mean, I was around at that time, but not involved specifically. One of the reasons we went from, most of them, like I said, were 1 year. Skull-based was done in some of those. Some were just advanced otology, free-for-all. When it was ACGME approved, it went to 2 years. The requirement to be an academic affiliated program was also included because most of them, as I said, were private practice. So, Doug, to your point, all the private practice programs went away with the exception of House and I believe at Michigan Ear Institute, which we then had to have this loose affiliation. I was actually the designated institutional official for the House practice as a single specialty. We were loosely affiliated with USC until one of our reviews came through and said, hey, you're supposed to be affiliated more closely. And anyway, so there are issues when you start doing this affiliation. That being said, one of the reasons we went to 2 years for, and the numbers, was most of the academic programs at the time did not have 2 years of 25 acoustics. They weren't doing 25 acoustics in a year. So you had to go to 2 years so that most of the academic programs could do that. That's not an indictment, but that's just my perspective of the time of why it was created to be 2 years at that time. Changing topics, one of the things I think we're missing in this conversation is the indictment of residency training in otology. Because people are coming out without feeling comfortable in otology, but yet that's supposed to be a core competency. You know, 35 years ago, I remember we had a board meeting for the AAO, and people were talking about the idea of a 2-3, meaning 2 years of general ENT, and then 3 years you'd kind of go into a pathway, so you'd actually look at subspecialty. You know, as we know in otolaryngology, there's like 10 procedures that are most common procedures that are done, and yet we have all these fellowships, and programs pride themselves. Many times the chairs I hear them talk about, oh, you know, 50% of our people go in and do fellowships. To me, that's an indictment of your program if you really require that many people, because Doug, as you said, it's an expense to have these people as indentured servants for the residency program, and at the same time, it's a cost not just to them financially, but it's also a cost to the public health system in the sense that we're taking people out of being practitioners to treat patients on their own, and yet being in a university setting. So I think there's some issues that we need to think about with that. Historically, most of the people, especially anybody who's been in practice for 30 years, did a 1-year fellowship or trained before 1997, and yet they were competent. And what I found in training fellows for many, many years is that some people get it after a year as far as the advanced skull base, and some people need 2 years. The 2-year fellowship, what I see what it's done is it's taken where we had maybe 80% of people came out very, very competent, to now we have about 98% come out very, very competent in advanced otology and skull-based surgery. The other problem I would look at, though, is you also have people coming out of a 2-year fellowship, and most of them go out, or half of them might say go out and they just do general otology. Most of them aren't doing skull-based. So I think this is a very important topic that we somehow have to figure out. My opinion, again, great panel, great thoughts. There's a lot of conversation here, and we're really kind of, I think, stuck in a situation where I don't think we're doing both the residents a service or our patients a service by requiring everybody to do 2 years and then go general otology or have to not be trained in otology if they really want to do that.
Yeah, great thoughts, Bill. Thanks for
If I can
bringing those
also
up.
just
Yeah,
say,
absolutely. Yeah, please.
I mean, do we have evidence that extra training gives you better outcomes? Is there any research out there?
Good question. I don't know, Jay, any thoughts?
I won't answer that question. But like Bill, I was not involved in the process, but I was around and observed it. And the reason it's called a neurotology fellowship is because when Bruce Gantz stood up in front of this audience sometime in the 1990s and talked about a fellowship in otology and neurotology, he got crucified because the general certification is supposed to provide otology training, and people didn't want routine ear surgery to be classified as something that only a fellowship-trained person could do.
Yeah, very true.
And so we're revisiting this exact same issue now.
I think the national standard right now is that 62% of our trainees complete a fellowship, right? Not just in neurotology, obviously.
I mean, we have some residents who finish residency incredibly competent at ear surgery, and we have others who don't. And I suspect that's extremely institutionally dependent and resident dependent. I think that'll always be the
Thanks,
case.
Jay. Yeah. Todd?
Thank you. Hey, Todd Hellman. So I'm going to be in the minority opinion. I would like to see the ACGME out, and I'm an ACGME super fan. We just started a program at Allegheny Health Network. I'm the program director of a new residency. I'm a super fan, but I want to see the ACGME out of the advanced otology fellowships. There's too many variables out there of these trainees that why they want to do a advanced otology fellowship. There's too many variables in the regions that they're going to. I mean, they may just be wanting to do a little bit of chronic ear surgery, just be the best person in their group. Some of them do want to do skull base, and we should let that sort out. As a program director, one of the biggest requirements to graduate a resident is going to be their ability to self-assess what their limitations are. And if they can't do that, then they probably shouldn't be even practicing general ENT. So those are the people that we're getting our grads from ACGME approved residencies, and they won't graduate advanced otology fellowship unless they also have that insight. And I think I would just let market forces sort it out. That's just my opinion.
No, thanks, Todd.
I'd like to echo some of the comments from my friend Bill Slattery. I've spent 26 years training residents from multiple different programs, easily 100 residents. And the elephant in the room that the panel didn't really discuss is exactly what Bill said. Our residency programs are not emphasizing or teaching care of the ear. The residents that come through can rattle off T&M staging systems. The name of the specialty has changed. The otologic component in our residencies needs to be enhanced greatly. I don't know what that is, but that's one of the reasons we're in the shape we're in, where very few people feel competent and capable of doing otologic surgery unless they spend extra time emphasizing it. And I would agree with Doug Backous, that's a very expensive proposition for people, especially in this day and age.
Yeah, I thank you. Thank you. Jay?
Morning, thanks for the really interesting panel. This is actually a question more than a comment. We were talking a lot about case numbers, and my question is, of the existing fellowships and the graduates from those fellowships, what percentage of fellowships do we have that actually are close to those minimums? Because I would guess that is very few. Do most fellows graduate with this 50 to 60, or do we have a significant number who are graduating with 26?
Yeah, Rick, do you want to take this?
I don't think we have that data.
Yeah, we asked for the data preceding this panel, and it wasn't shared with us.
I mean, I think it's a lot of hearsay, right? There's no accountability of how many, send us your case numbers, and we'll collate them all. That just hasn't been done.
So they're collected, but we never see them?
We asked for some of them from the board, but again.
And from the ACGME.
Yeah, and they weren't shared.
Yeah.
However, the ACGME will put a program on probation if they don't meet those minimum numbers.
Yeah, sure.
So I think the other thing is numbers. And so for my fellow, it's he or she and I for the year. They're doing every single case. They're not competing with residents. There's not two fellows that are both claiming the same case. So I think numbers can be very different things to people as well, to your point. I think, Rick, kind of, when you talk about minimums, what are they actually putting their hands in and doing is a question.
So last question. Sorry, Peter. Yeah, sorry.
So we've had a lot of conversation about numbers, but I'd like to just kind of reframe this conversation because the numbers aren't the competency, right? I'll put this to the panel, the person who attests to the competency of a resident or a fellow is the program director or the person who's overseeing the training. The certifying agency is the ACGME or the fellowship certificate or what have you. But if the concern is that there are people in practice that are not reaching minimal competency, who is saying at the end of the training that they're competent, that they're completing the program, regardless of how many numbers they have? It's not all about the numbers, and increasing the numbers doesn't change the judgment that must occur on the part of the director to state, have a conversation with the trainee and say, how are you doing? How do I think you're doing? Are they the same?
Can I say something about that?
Sure.
So, to me, you have two organizations, ACGME and ABOTO, telling us, like, these are the bare minimum numbers that you need to be safe. So to me, if you pass those numbers, you're competent. What I think we're talking about is proficiency, right? Getting better, getting faster, getting safer. And I think that comes with cases and time. And, and asking questions and asking your colleagues to weigh in on something, I don't think it should be frowned upon. And being hypercritical and judgy about because I asked a question, I don't think it's the right way. And I think, if we use our skill sets and use our partners to elevate the patient's care, I think that should be the end goal. I mean, the last time I called Mark, to discuss a patient is, say, 4-year-old with, a stenotic ear canal with a raging cholesteatoma, and she's autistic. So, getting his thoughts on how would you deal with this kid that's not gonna let me clean her ear ever in clinic, so these are cases that are doing all the time. So using each other's skill sets, using the bare competency numbers, but then using your skill sets to elevate each other, I think should be the end goal.
Yes, thanks for, unfortunately, we're out of time, right? I think we're going on the break. Sorry, Mark, I didn't cut you off. So yeah, in conclusion, so thank you very much for participating. Obviously, there's Thank you.
That's right.